couple of days ago. It was crazy.
So Jamie, I think people are joining us from the waiting room. I think we need another few minutes to get, and then we'll get started. I'll turn it over to you for intros and housekeeping.
Yep, perfect. You see a bunch of people joining right now. So.
Yep.
Give it another minute or so. Yeah, here we go. So welcome everybody. We're excited to have you join us again for another one of our director series. As you all know, I mean, I think most of you have been part of or at least heard some of our presentations before, but our goal is really to kind of push our thinking and be open-minded and kind of come up with new ideas so we can make sure that our work continues to be continues to resonate and be as impactful as possible. We're so lucky today to have Dr. Crear-Perry join us today for this really exciting discussion. Just so everyone knows, this is being recorded, obviously for internal purposes only, and we'll be sharing the links to our internal site for folks who missed this conversation and want to make sure that they can see it again. We'll be sending that out as soon as that's available. And please keep your questions. We really want this to be a dynamic discussion. And so please put your questions in the chat. And after there's a conversation between Dr. Meyers and Dr. Crear-Perry, we'll come back to those questions. So with that, I'll turn it over to you, David, and to kick us off.
Thanks so much, Jamie, and thanks you to the entire team for helping organize this. I'd like to remind everybody that this is being recorded, as Jamie mentioned. In the director series, one of the things we asked staff is what topics we wanted to have our thinking advanced on. And people came back and said very clearly that they were excited about our journey to increase health equity, but also how AHRQ can become a more just place to work. So we looked for somebody who could really help us think in both of those areas. And on top of that, the department has a new priority, a new leading priority in 2022 on improving maternal morbidity and mortality in the United States. So it is a delight for me to be able to welcome and introduce to you Dr. Joia Crear-Perry, and you'll understand as I read her biography why she can help us with all three of those areas. How we can be a more just organization, how we can build a framework for health equity in our work with the health services research community and the health delivery systems, and also how we approach maternal mortality. Dr. Crear-Perry is a physician, a policy expert, a thought leader, and an advocate for transformational justice. She's the founder and president of the National Birth Equity Collaborative, NBEC, and she identifies and challenges racism as a root cause for health inequities. I loved that in her bio, she concluded it by stating, her love is her family, health equity is her passion, maternal and child health are her callings. Before establishing NBEC, excuse me, folks, she served as the executive director of the Birthing Project, director of the Women and Children Services at Jefferson Community Health Center, and as the director of clinical services for the City of New Orleans Health Department. In that role, she was responsible for facilities that provided healthcare for homeless, pediatric, women, infants, and children, and gynecologic services within New Orleans. She was also there and helped work on improving availability and utilization of healthcare for all New Orleans citizens after Hurricane Katrina in 2005. She has received funding from the RWJ Foundation to work in collaboration with the American College of Obstetrics and Gynecology to develop a standard for respectful maternity care. She also serves on the National Quality Forum's Maternal Mortality and Morbidity Committee and the Joint Commission's Perinatal Safety Project Technical Advisory Panel. She completed her undergraduate studies at Princeton University and Xavier University, and then received her MD from Louisiana State University, where she completed her residency in OBGYN at Tulane. She's also recognized as a fellow of the American College of Obstetrics and Gynecology and as an adjunct professor at the Tulane School of public health. In 2020, Dr. Crear-Perry was honored by USA Today in its Women of the Century and featured at ABC's Nightlines Hear Her Voice. She's twice addressed the United Nations Office on the High Commissioner for Human Rights, elevating the cause of gender diversity and an urging for human rights framework to address maternal mortality. She has received both a Congressional Black Caucus Healthcare Heroes Award and a Global Visionary Award for commitment to advancing women's health from Harvard University. Dr. Crear-Perry, it is a pleasure to have you with us today.
Thank you, David. We can just go by David and Joia. Is that okay?
That works for me. And I wanted to let folks know that we had a chance to meet in advance and talk about both AHRQ and NBEC and what we wanted to do together. And Joia said to me, she likes to take the early part and set the frame. And so instead of just doing a dialogue, I'm going to cede about 10 minutes for some slides just to help us all move this discussion forward more quickly. So I'd love to do that now.
Thank you, David, so much. And I know that you all are so brilliant and researchers who've been keeping us safe at AHRQ. And so I just want to thank you for allowing me to bring in some of the frameworks that we use and reproductive justice and birth equity, and hopefully they will be helpful for you all going forward. So Jenny, next slide, please. So our organization is now almost 7 years old, and we were founded originally with funding from Kellogg Foundation to work on Black infant mortality. And although I am a 50-year-old Black woman sitting in a 50-year-old Black woman's body, like many of you, we have forever been ignoring women's health, maternal health, the wrapper around the candy. Fortunately for me, about 6 months into the founding of our organization, I was invited to the Mother House in Atlanta, which is the home of Sister Song, Reproductive Justice organization, where we were talking about the fact that Black women were dying in childbirth at 3 to 4 times the rate of their white counterparts in the United States. So we were able to add maternal health to our mission and vision and get rid of that blind spot of only focusing on the infant and not thinking about the wrapper around the candy. And our vision is that all Black mamas, babies, and their villages thrive. Because if you only focus on one part of that equation, you're going to mess up all the rest of it. Next slide, please. And when we started as an OBGYN, especially practicing in New Orleans, many of my patients, only getting to see them for 10, 15 minutes, that clinical interaction was so limited. And our organization understands, as a previous, and as it was mentioned, working in public health, that your social interaction, the social infrastructure really is where your health is determined. And so our organization is this mixture of both clinical plus social. So that means we have to dismantle systems of power and racism, and really educate ourselves on the social determinants of health inequities. Next slide, please. So we looked for a definition of health equity. I'm on a lot of these calls and a lot of meetings, and people get very stuck on, what do you mean by equity? So the first thing you do is agree upon what your goal is for equity. What we're talking about. Common language is so important. So when we looked at all these other definitions for equity, Healthy People 2020, Robert Wood Johnson, they use words like fair, or they use words like place. We're gonna, equality, fairness. Well, those words are very fraught. It's easy to think, people can think it's fair. Fair is a subjective term, but we know that equity, and also we know that there's this journey of getting to a place where everything's equal and we can all sit down and relax, that on our current political and world situation, we know that sometimes you get a few steps forward and then 10 steps backwards. So this idea that we're gonna get to this place where all things are fair and equal and we can hold hands and sing Kumbaya is not a reasonable expectation. The same people who are today hoarding power and wealth are teaching their grandchildren to hoard power and wealth. So if we're going to have equity, health equity, our job is to put the assurances, the policies, big P, like ensuring that people have access to healthcare coverage, no matter their income, age, or geography, or job, not tying your insurance coverage to a job, or policies, little p, like what hours someone is open, or are you kind? Do you listen to your patients when they say, or do you have empathy, right? So the assurances of the conditions for optimal birth, instead of thinking about your job is policing people's individual behaviors. Your role when it comes to equity is creating the conditions through your power, to the conditions for optimal births for all people. So believing that all people can thrive and be seen in the future. Next slide, please. So from that definition, we created our definition for birth equity. We looked at definitions for human rights. We looked at frameworks around reproductive justice. We looked at all the ways in which the goal for having all Black mamas, babies in their villages thrive. What would birth equity mean then? You have to have a definition. So it's the assurance of the conditions for optimal birth. We don't want people in the United States or around the world just to survive pregnancy. Mortality and morbidity are not the goal. We want them to thrive, to live their best lives. So that means we must be willing, we as a country, as a community, not just blaming and shaming the mamas and the babies. We have to be willing to address racial, because we made up race. So we made it up to be harmful. So we have to create policies to undo the harm that we made up, and social inequities in a sustained effort. A 2-year grant is not going to fix this. Even a 5-year grant is not going to fix this. This requires us totally realigning and understanding that the people are not broken, but the policies and the procedures have been trying to break them. So our job is to now invest in them and to see them as in the future so that they can thrive. Next slide, please. Everything is a thing with a history and a set of relations. Understanding anything in our everyday requires that we know something about how it arose. How did AHRQ arise? What were the conditions that it became a thing? What was the point of even making your organization exist inside of federal government? Have you all asked yourselves that? And develop and how it fits into the larger context of which is a part. How do you fit today based upon your origin story inside of government and where we are as a country and a world when it comes to health? How does that fit into the larger context of your work today? Have you paused to think about that? It's important to note that when we speak of systems and institutions like AHRQ, we are still talking about people. All of you, everybody on this call, are collectively organized in a way that is based on a particular set of rules and relations. So you're a part of a big system, HHS, AHRQ, but you're still individuals who have power and collectively organized can move an entire organization, entire country to do something amazing and beautiful and just. Next slide, please. So that means you have to understand the framework that we're currently operationalizing. When I say blame and shame and harm, that is a framework of a belief in a hierarchy of human value based upon skin color, which was codified into law, into policy. The policies that came out of agencies at HHS, policies around eugenics, policies around the places where we could live, where we can grow. I mean, I went to medical school at a school where the hospital was named Confederate Memorial 100 years after the Confederacy lost the war in 1956. I was there at medical school in the 90s. They had just rechanged the name away from Confederate Memorial. These are symbols and a belief of a hierarchy of human value that were codified into cultural and policy symbols. So our job is to say that truth, to understand that that's the framework that makes us think that people are broken and create policies for strategies for quality that says I need to fix broken people instead of to fix the broken system. So a framework can be a vision, expand our current reality, allow us to look for new indicators, think about new ways to look at our traditional data collection application. We have to question our current construction of our healthcare system. It is broken. We can't keep just adding measures on top of the broken system. White supremacy is the current framework from which this culture is derived. And as a result, many of the action that we are taking are influenced by whiteness without us even knowing it. We're not even paying attention. We just do it and we don't even realize that this was codified from the beginning, to believe that Black women were just here to create babies for use in chattel slavery. That belief system still holds in how we talk about Black women today when they're birthing in the hospitals. Next slide, please. Human rights is a framework that our president says he believes that healthcare is a right. Every other high income, I'm so excited that he said that out loud. He's the first president that I know of has said that out loud. Now we have to help him to make that right into an actual codified truth in this country. Because every other high income nation believes that health is a right. So they do things like free childcare. They do things like free having paid leave, right? So health is a right is not just the transactional nature of having access to Medicaid or Medicare card. It's believing that all people should be invested in and should have the ability to form a family how they choose. In every other high income country, in vitro fertilization is covered on public insurance, not just access. Here we can't even get it covered on your job insurance, on employer-based insurance, right? So believing in a human right, how can AHRQ help us to codify health as a right in this country? How could you use your power and what we count and what we measure to show that we need health for all and health to be a right? That's a just organization. Next slide, please. This is Loretta Ross, She's a mother of the movement. The title of this book is Intro to Reproductive Justice. We just did an op-ed in the New York, article, ad in the New York Times where you might see about this, but reproductive justice is a framework that was created by Black women in 1994, and it asserts that we have the human right to decide if and when we have children, parent those children in safe and sustainable communities, and personal bodily autonomy. If your framework for thinking about maternal health is one of eugenics, of white supremacy, of blame and shame, then you do things like say, well, these moms, if only they would get prenatal care, despite the fact that the data showed us, even when we get prenatal care, we still are more likely to die in childbirth. Even when we have a college degree, we're still more likely, 5 times more likely to die in childbirth. So continuing to blame and shame us instead of investing in these rights and this justice is how we have the worst outcomes in the world. Next slide. So this is our birth equity agenda. We are asking for reproductive health and autonomy to be promoted at the highest levels of government. We're asking for the president to continue on this journey that health is a right, and then to recognize it as a right and codify it as a right. Individuals and institutions need to be held accountable for these disparate acts. We are now finally starting to collect data around health disparities, but we do nothing to actually hold hospitals and systems and providers accountable. We went decades without counting maternal deaths. We didn't value women at all, value birthing people. So for no more can we have maternal deaths go unnoticed and uncounted. And lastly, most importantly, the government's involvement in any reproductive health should not ever intrude on reproductive freedom, agency, and autonomy. Next slide, I think that's it. Next slide, please. Oh, that's not it. This is our cycle to respectful care that we created with the American College of OBGYN. And that I mentioned with funding from Kellogg. Next slide, please. And that's it. Thank you. Sorry, David. Hope I didn't talk too much.
Oh, please don't apologize. That was awesome.
Okay.
Thank you. We
Okay.
need to move in. We're going to go deeper though, and I hope people are already starting to formulate questions. I had so much fun, really. I was inspired reading the National Birth Equity Alliance's website, and it struck me that you all and we at AHRQ are great partners, because on your website you state, and I want AHRQ to recognize this, that research and scholarship is the backbone and the heart of everything you do within NBC. But an NBC like AHRQ then uses data and research as the starting point for action. Like AHRQ, your organization provides technical assistance and partners with healthcare organizations in this journey to promote birth equity. But as an NGO, you get to go a little farther than we do. You engage in policy advocacy. And when I read on the website, so I got excited by that part of it and that you're doing that work, but was fascinated that you then linked that back to creating culture shift. And I think you laid that out for us here. But at AHRQ, we're interested right now in this question of how, as a government, health and safety, quality and safety organization who uses research and data to help drive the care delivery system, how do we partner with care delivery systems to help them understand their power to change their narrative, to change their structures, to root out structural racism, the things that you were talking about, the policies, the attitudes, the structures, the measurement systems that are not driving us to the framework that we believe we should have. How do we engage with them? So I'd love to hear your experience with how you partner with delivery systems to get them moving on this journey to admitting, recognizing, addressing, being motivated for change. I know you do that in maternity care for women and for the babies, but I think there's something larger there.
Oh, yeah, definitely. We've done it in other systems too. So first, thank you for showing that alignment, because that's important and critical. So I appreciate that. And probably the reason we get to do that with agencies is similar to you all. So we get invited to help with community engagement. That's usually what the term is. So when our organization started, hospitals and systems would say, hey, we're getting beat up around not having community engagement. Can you and your NGO come help us with our community engagement strategy? So power building because we're a just organization, we would say, we can't just come in and check off the boxes just because you're a hospital with power and you need to do community engagement because an organization like you know, an NCQA or some accreditation organization is telling them to do it. They're not doing it out of the goodness of their heart. So your policymaking actually creates room for people like me to make justice. So I know that there's a policy that says you're supposed to do community engagement. So then I go, okay, here's NBEC, we're gonna help you with your community engagement, but we're gonna start with, instead of you using us to just take what you have and give it to the community, community engagement to us means community power building. So how does AHRQ think of community engagement? So when we change our language to community power building away from community engagement, that meant our job was not just to engage the community, but actually to use our power to help the community build their power, right? To let go. So community tells us what they want, not us giving our feedback to them. So that means when you think about our research, we asked the community, we did a birth equity index. Instead of us pulling data out of the sky, we asked the community, what are the members, Black women, what are the reasons, what happened to you in childbirth? And then we pull data from their actual experiences. So I think the fundamental difference is that we start with believing that the community has the answer. And so when you believe as a researcher, as a hospital system, as a federal agency, that the answers are already there, they're in the community, and now your job is to unearth them and unsurface them and invest in them, then you approach the work very differently than when you believe you have the answer at an academic institution or at the federal government, and your job is to tell the CBOs, the NGOs what to do. That orientation is totally different, and it makes us get the answers wrong when we think we have them inside of our offices instead of in the community. And I'll give you a concrete example. Joia perceives that we need to have more Black women OBGYNs. I'm a Black woman OBGYN, and there's, like, in my mind, very few of us, but the data shows us the patients want more midwives and doulas. I could go around the country and use my power and say over and over again, we need to have more Black women OBGYNs because that's what I believe. But when we actually ask birthing people what they want and what the data shows, what every other high income country has is more midwives, more access to near peers. So I use my power as an NGO to change that to actually do what the people want instead of me saying what I want. That's what I find happens frequently.
Oh, so much there. And I'm guessing my colleagues in our patient safety world are nodding along, because I think AHRQ has been in advancing this idea that within safety, we have to engage with people and their experience of the safety culture and their guidance of the health system. So we've done a lot of work on patient advisory boards and listening to patients, engaging with patients to develop safer systems. And I think the advice you just gave us is we need to take that paradigm into quality, into measurement, and into equity.
Yes, that's exactly
okay,
what
so
I'm saying. Because I wouldn't have been able to do this work had y'all not been making them do that for that one area.
Right. Well, and that was another wonderful example of sometimes putting in the policy that won't itself achieve it will direct people to the place where then they'll engage in the work. But I want to go on a place where everybody at AHRQ knows I gave you permission to make us uncomfortable, and that's what we're going to do today. And I think whenever I think in this country still, talking about race and talking about inequality brings up
emotions.
Yeah, exactly, emotions, and there's a long history here. What have you found, and I'm asking this both for AHRQ in our own work and for AHRQ when we go out and we try to work with health systems, in both cases, have you found things, ways, approaches that help bring those people who are hoarding the power to allow them to move forward? Are there strategies for engaging them in this transformation?
And one of them I just tried to do, which is show my own growth, right? And so the more that you can, I think racism is not a mean person. Like when I first started talking about racism 6 or 7 years ago, people would get so nervous because we've characterized it as mean-spirited people do mean things. And I finally realized I have a son who was born premature. He wears hearing aids. So we don't tease him about wearing hearing aids. We just accept him that he wears hearing aids, and we're like, oh, you know, we love him that he's hearing impaired, okay? People perceive that's what racism was like, that Black people are broken, and the mean racists are the ones who pointed out and teased them, right? So just saying, oh, Black women are dying in childbirth because they don't get prenatal care, that's not, you know, you're not, that's we're not racist if we're blaming them for not for dying because they don't get prenatal care. What becomes a racism is that we're not dying because we don't get prenatal care. In fact, we have, when you pull out the data and disaggregate it, we die when we show up for prenatal care, we die when we're normal weight, we die all these other ways, but you still hold that bias. That's the belief that we're broken is the racism, not the teasing us because we're broken. We were never broken in the first place. So getting people to that, to understanding that I had to unlearn that myself. So I had a baby, my son who's 25 now, I had him in medical school, he was born premature. And part of me making my organization is because my only risk factor was being Black. I was married, I was intending to be pregnant. I did not drink at the time. I now have liquor all over my house, but at the time I didn't have any of that stuff, right? So this idea that I, as a physician, who was raised by a physician and a pharmacist. So I didn't grow up without things, like all the stereotypical things that I was supposed to have wrong with me. And I still had a baby that weighed a pound, right? So how do we get people, I had to unlearn that I didn't have a different kidney, that I was taught that in medical school. I was taught that there's a android pelvis. That was in the textbooks that we had. So I believe that we had babies early because Black people just had babies early. So I'm unlearning that myself. So as I'm on my own journey, I don't expect white folks to have already known that. If I'm unlearning it, why would you know that, right? So the more that you can humble yourself in your own lifelong journey when you're going to systems, that this is not something we're all figured out all the time. We're learning this constantly. I'm unlearning. My journey on gender is a hot mess. Trust me, I mess up all kind of stuff, and I'm clear, so it makes me very empathetic when it comes to other spaces. So being humble, kind, sincere, we're on a journey, but also still not using it as an excuse not to have change. At the core, we're not saying, oh, we're just figuring it out, we need to stay the same. We're figuring it out while we are doing actual just work, while we're ensuring that people in the community are on the board of the hospital, that people in the community are the physicians and the nurses, the people in the community are part of the decision-making. So.
Sorry, I'm trying to process all of it, and I'll come back and watch the video and do more of that. So relationship building, humility, admitting our own growth, or not admitting, leading with that we have work to do.
It's a strength.
Is a way to de-escalate that emotional reaction.
Yes.
I also heard, though, I think in that it's about our culture, our history, structures, and that should be something that recognizes with AHRQ that the blame in our, again, maybe it's using our safety example, saying doctors and nurses just have to work harder and be smarter and then we wouldn't have errors,
right,
does not help.
It does not help.
Well, blaming the people, so that blame and shame is not what does it. And in fact, it can make it worse because people then hide, and saying we're all human and that it's a system and we want to fix the system. So maybe that'll help our team as we both do our work and as we move forward.
Yeah, honestly, I hadn't thought about it. You just said it like that, but so much of the culture, safety culture in the hospitals where I worked was hiding and shame. And that's not going to be conducive to, so I was talking about shaming patients, but you're right, hiding and shame of providers, it was huge. Like there's a culture of not transparency. Think about even peer review, the word peer, as we become more diverse as physicians, who's our peer? I don't think the same as a lot of my white male older friends. So with colleagues, my peers, so when they would review how I provide care, they're never going to think it's adequate. Right? I'm got the patient on a nurse on a ball, she's going for hours, they are doing pit, and do a C-section. So this idea of like, who is the shame and the culture of hiding in the peers, protecting each other and not protecting the patient is what this has created.
For the non-medical people, and I've helped enough women with delivering their babies that I was with you there, but the idea of aggressive medical intervention, doctors know how to do things and they just take charge, versus what you were saying, which is a very patient-centered model of delivery.
I was always teased of being written up for listening. I literally was written up for listening to the nurses too much. I've been listening to the nurses too much. Whole write-up. Like somebody took the time to write that down. So I was like, you don't listen to the nurses? They're here with the patients.
I was going to say, there are a whole bunch more levels of problems there about hierarchy and power. And where the real knowledge is.
Right. That's
okay.
So if your orientation is the real knowledge, that the patients have the most knowledge. So that's how I walk into every room, no matter who the patient is, no matter how much education they have, that they actually know their bodies more than me. No matter how much education I have, no matter how much information I have, that each individual, each human being is the expert on themselves. That is the opposite orientation of my peers historically in medicine, right? To believe that I am the arbiter of knowledge and I'm here to distill my knowledge upon you. And I do think that fundamental shift in who is becoming physicians and who is working in healthcare is also having us a little schizophrenic in the field, right? So the field is moving towards this orientation of, oh, patient-centered care. So you have folks trying to figure out what that means. And so for me, patient-centered care means exactly what I just said. I believe that the patients, so I don't need a fancy toolkit for that. It's how I operate and move in the world. I don't need you to train me on how to do that. It's just my belief system. There was a time, oh, this might be helpful. So white supremacy, there was a time, the reason I brought up this, that my hospital was named Confederate General, is because it was named that in 1956. The Confederacy that didn't win 100 years before that. So there was a culture shift, a desire, a concrete desire to make the culture of white supremacy seem normal, to do things like name hospitals Confederate General, to put statues of Robert E. Lee in New Orleans, where, although he never even came to the city, but it was the biggest statue in the city, to put things in my textbooks that said I had android pelvis and that my embryology professor at a state university in the South in medical school taught us in class that there was Negroid skin, Mongoloid skin, and Caucasoid skin, right? So this was white supremacy placed into textbooks and taught to people like me who are now practicing physicians across the United States. So when I say that we need to add just and say undo that, unlearn those things and undo that harm, this is for fluff. We physically have to unlearn the harmful things that we were taught, like the reason that my baby came early is because I have a different pelvis, or we must have a different cervix, or we're looking for a Black placenta. There's no Black placenta, there's no Black pelvis, there's no Black gene. So letting go of all that, then you have to really rethink, well, what is whiteness? What is Black? Like all of these things become very hard for people to hold and they don't know where to go. So if you center justice, you get there faster, right? So if you say, okay, this is a lot, this is very different from anything I ever learned. For me, it's very different from everything else. So how do we talk about preterm birth? Because race is a social construct. Why am I tracking people's race since we know race is a social construct? Because if you held it so long that it was biological, it's hard for you to imagine what you need to do with that information now that you know that it was just made up. But what you do is you create systems and structures to undo the harm of that made upness. That's what you do. So you have to figure out where was the harm, what are the social determinants of health inequities that are causing harm based upon race, gender, ability, age, and then how do I create data structures and measures to end that? Like that was a long.
Okay, so many cool ways to go, and right at the end you brought up measurement, which I want to get to, but before I even touch on that, no, actually maybe this is the entryway into measurement. One of the challenges our staff I'm having, I'll say admittedly that I'm having, race is a social construct. Biologically, it doesn't exist. In reality, in this country, because of our history and our culture, this imaginary thing, it happens, right? Yeah. How should we be measuring? Because I believe we should be looking at all our quality and safety outcomes that we're trying to achieve to understand if there are inequities. Exactly. So we know where there are areas to focus on finding the systematic problem. Agreed. But on the other hand, then some people say, but if you're measuring that, then you're recreating.
I know.
What is the frame that I can use to explain why it's important to still measure this imagined concept?
Exactly. Well, I mean, I think when we think about respectful maternity care, in our little cycle, one of the things is the lifelong learning. And the first step is internal work. So reading and unlearning and undoing. So the reason that we are always afraid to keep using race and keep counting it is because people have used it for so long for harm. So part of the reason that we start with this initial learn yourself, because that way when you talk about it, it won't be harmful. Like if you were measuring race, David, I wouldn't be nervous. I'm being really honest. When you are collecting it, I'm like, cool, David's doing this. He understands structural racism. So when he checks off on this piece of paper that I'm Black, he's not doing this to blame or shame me. He's doing this so he can look at the structural racism reasons that this is happening. but I trust you, David. I've been around you. I get that this is something you want to do. We have not built that trust with all hospital systems data collectors. So when people don't want to check it off, they don't want to check it off for good reason, because it has been used for harm. So to get people to check things off and for us to move forward, we have to do self-work so that they can be trusted, so that when they check it off, we know, okay, this was good. This person really wants to help me. They want me to check this off. I can tell you in places like Louisiana during COVID, my colleagues who were in public health still there told me white people were not checking off their race. And you have to ask yourself what that is, that the mistrust around race is now starting to come into whiteness. So we need to really get a handle on our understanding of race. White people need to get a handle on their understanding of race, what that means for them. Like, we have spent a long time as people of color trying to understand race. White people have not. And so it's like figuring out right now, as we're moving, we're going to still keep you. It's not going to go away. So we don't just all act like, oh, those 400 years didn't exist. We treated y'all crazy. We're going to just move forward. The world is gray. No. We're going to still keep counting by race, but we have to then say, what does whiteness mean? And then what does that mean for your health? Whiteness and health does matter. David Williams has a whole framework around mental health and whiteness. So please continue to count race, but learn about what race actually means. Don't just ignore race now that we figured out that it was always a lie, that it was biological. Learn sociology, learn history, and then treat race like it is a social and historical and racial, social and political construct.
Right. So being the small-minded Fed that I need to be, the way I think I would retranslate that is that race is a socioeconomic construct in this culture that has been used. We have to intentionally use it to undo structural racism, to improve people's lives in our culture. So we are going to collect it so that we can hold ourselves accountable, which is one of the things. And that's creating trustworthy healthcare institutions, people, individuals within the system. But when AHRQ works with healthcare systems, explaining to them what it means to become trustworthy can be part of this journey. Okay.
Exactly. And then because here's where the lie comes in. We use race conscious laws to create the inequities, right? Like, so to act like we can use race neutrality to undo them makes absolutely no sense. So like, redlining is a real thing. It was written down. Segregation, access to student loans, car loan, like all these things are real. So and then you're going to say, okay, well, now the world is gray. There's no biological basis of race. So we can't, everything's race neutral. Makes no sense.
So I try not to be watching, but the dialogue that our team is having, the staff, but one just popped up that I think is important. I've been using black versus white. We should recognize this is, and you've already done that. There are many, America has a special interest in white versus non-white.
They do.
So that is our culture. But you've also pointed out this is about gender bias that's been built into our system. It's about sexuality biases, age. I think you brought up disability status. Yeah.
But even across the race thing is so amazing to me. Like right now, I'm on these panels where, like Robert Wood Johnson recently sent out a release, and the AMA, the MENA community would like to no longer be considered as white. Think about the politics of the moment that they were placed as white. The census deciding who is white and not is such a political act in the first place. And then the politics, and I'm on this call with these brilliant researchers from the MENA community who were mad that they were like, why would they even call us white? We get no white privilege, right? So this idea of like, and I was like, yes, the whole point is not Black. So for hundreds of years, if you could get this country and not be considered Black, you could buy a house, you can buy a car. So if you were Jewish and not Black, if you were MENA and not, whatever, as long as you are not Black, that is how racism works. So I'm using Black because that's how racism created this structure. There's a whole whiteness in my world where I grew up in the rural deep South. It meant Christian, Protestant, white man. So it was patriarchy, it was Christian, it was a whole bunch of y'all who were on this call who would not be considered white where I was growing up. You would have tried to go to a white meeting with the Daughters of the Confederacy, they would have kicked you out. So whiteness has expanded to keep power, to keep a majority. And the only other thing that people can see as the opposite is Blackness. And so that is why people talk in white and Black.
Oh, this is, perfect introduction to what will hopefully, and it shouldn't be, but next month there'll be a lot of focus on Black History Month.
Oh,
And
yeah.
these are really important concepts that will continue, and it's not just that month, but this is
And I
all
would
great.
say this too, that race, because it's also taught geographically. So when I work in international spaces, like people think of race very differently. So many of the people who work at AHRQ might not have been socialized in the US context. So their idea of race is just all thrown off, right? Like the first time they hear that they're Black, even though they're from Nigeria, is when they get here, right? Because everybody looks like them where they are. I went to South Africa and people thought my daughter was colored. We don't have that word here, right? So it's just like all the ways that this made up idea has been codified in your context. People then have made it to biology and to science, and it's not biology and science, but the impacts are biological and scientific.
Let's write that one down. I have so much more. I'm throwing out every question. I'm just going to jump to the end because I want the team, the staff, to have a chance to ask you questions. But so my last 3 questions I ask all speakers: are there anything that you haven't already said that you wanted to make sure our staff heard? Second question: who else should AHRQ be listening to, learning from, and partnering with? Just list some names. And if you don't have them today, send them and we'll send them out to everybody. And then related to that, staff, our AHRQ is a learning community. It's one of our highest values, continual learning. So are there resources that you recommend for people who want to explore ideas that you've been sharing and go deeper?
Yeah, I mean, this has been such a great conversation, David. I could talk to you all the time. So,
yes, I'm going to follow up, but
yeah, but I
for
do
this
think,
group
today. So we have resources that I will definitely share. My team will share. I would say that the Black Mamas Matter Alliance website has an amazing resource list. Everything from Loretta Ross's book to articles. If you don't want to read articles, I have a stack of books on my dresser that go between them all. Everything from right now, oh shoot, I can't think of the name. Black Feminism Reimagined. And so to your question of who else AHRQ should listen to, is social scientists, historians, sociologists, people who are in the non-biological sciences. Because what has been happening is we have, if you think about even our response to COVID, we have a dearth of understanding of the social context around us. And we have perceived a long time in healthcare and in medicine that it is the transactional nature of, think about the difference between having a standardized patient, the belief that you just have a body that you can practice on, which is what was happening when I started medical school, a standardized patient that you just learn on, versus following a family for 4 years. That if you were to have a medical school that had a standardized patient as their idea versus following a family for 4 years, the difference in what those learners would believe and see, the context around their lives, all the other things that happens. It's not the transactional, if I just give you a pill or a shot that you're going to be cured, but really following the journey of a person's life. That's the orientation that you should think of your work.
Oh, I want to, I'm so glad you're reminding that. I'm sure that my partner is going to, when I tell her you said that, is going to say, I've been telling you that for years, because we're actually having discussions in my family. For those who don't know, my wife is an American historian, and her community of scholars has been saying that our understanding of race and maternal morbidity and mortality, we're getting it wrong because we think on categories and we're looking at our statistics. And that when you actually unpack them in a cultural and historical context, we're mixing up things that we think we've separated out. And I'm like, oh boy, I got a lot more to learn. So thank you for underscoring that.
Probably can hang out with your wife.
Yes. Okay. Jamie, I want to invite you back because I'm having too much fun, but I want to let everybody else in on this conversation.
And I saw someone ask about one of the slides, and I was wondering, Susan Perez, if you're still here, the slide that we usually have for indicators versus frameworks, if you could share that with Jennifer so we could pull it up, that'd be great. Okay, let's keep going, Jamie, sorry.
Jamie, you're on mute.
Yeah.
Now it's a Zoom meeting.
Totally. I'll wait for that question until we get that, till we get that slide back up. But let's say, okay, here's one. Thank you for this thought-provoking discussion. I sometimes worry that interventions implemented at the system level a broken, inequitable system will widen disparities, not close them. I mean, you talked a little bit about this, but if you have anything else to add about what are
Yeah.
your thoughts and approaches to intentionally tackling and to solve these kinds of problems, to making sure that inequity isn't worsened?
Yeah, I mean, we have examples of that's happened. My colleagues in California did a great job of improving maternal mortality, and yet the Black-white gap worsened. And what I would say is the reason is that they weren't intentional about undoing the harm of racism on the patients, right? So one of the things they did was look at a lot of toolkits and standardized things and standardized patients and all that stuff without thinking about the biases that happen before people get there. So white women did a lot better. The gap did really great for the structures in California, and Black and brown women were dying more. So my advice is to structure your system and your intervention to impact the most impacted first. That the rest of the folks they'll be okay. Like if we were to fix the maternal health crisis for Black and Indigenous women in this country, white women it would be amazing, right? But when you make the orientation, when you make the intervention based upon the people who already have the most resource, and then say later we'll add on for everybody else, which is what our healthcare system consistently does over and over and over again. We have a healthcare non-system for middle class people who have jobs. And so then we add on for everybody else. What if we had created a system for a homeless person in rural New Mexico? What would our system actually look like, and how differently would it be? So when you create your interventions and your measures, pick the person who you're thinking of as the person who's the most impacted, not the lowest hanging fruit or the easiest to get to.
It's funny, it's making me think about some of our conversations when we had Mai speak with us about disabilities, and making sure that we, think about it from that perspective, and we probably will help healthcare across everybody's health if we think about it from that.
I used to use a little, probably everybody's seen this little slide about the cutouts on the sidewalks. They were made for the American Disabilities Act. All of us. I use it for my groceries. People use it when they're jogging. Like, it's like, oh, this is great. I use it when my son was little, so he didn't fall over. But it was really just for one group. It was for the most impacted group. That's and it helped all of us.
So getting down to the next question, this is getting into some of the work that we do, like very specifically, but when we're thinking about what should we be thinking about in our surveys to identify culture, racist barriers to safe maternity care. We also need, some maternity health plan surveys that can hold healthcare organizations accountable in the inpatient ambulatory setting. So what are your thoughts about that?
Well, we've been working with the American College of OBGYN to create a framework for respectful maternity care. We actually published it. And I had one of my slides was trying to talk a little bit about it. But what we did was, along with Johns Hopkins School of Public Health and AHRQ, was we interviewed Black birthing people about their experience and what it was like in care and what happens. And respectful maternity care is a term that's used globally, internationally, but we don't necessarily use it in the United States. And usually when it's used around the world, WHO and others use it, they mean low-income nations. But we know here in the United States, just because you have money doesn't mean that you're respectful. So this idea that we don't need to look at our respectful care here was fraught. So we looked at it. And patients told us things like they wanted ACT to be treated, they wanted trust, and not the way that we currently talk about trust. Patients want us to trust them. They want us to believe that they're doing what's best for them and their families. They want us to trust that they're trying. They want us to trust that they know their bodies. And that's not how we're trained, and that's not how we think. And so really reimagining what it would look like across all these systems for respectful care. This is one element of it, with the trust building the other way, bidirectional trust. And how do we build bidirectional trust? So there's others. Dr. Karen Scott has a obstetric racism measure that she's doing as well. And then my colleague, Dr. Kim Gregory out of Cedars-Sinai also has a patient-reported experience measure. So we're trying really hard to dig into the experience of care that people have. Not the same as customer service. I have colleagues in marketing and PR, and I understand the need for experience of care when it comes to customer service, but for Black birthing people and for Indigenous people or low resource people or rural people who have higher rates of death, their experience of care actually is harmful, that it can kill them if they are not trusted, if they're not seen. And so when we're talking about, this is not a customer service survey. This is a very real figuring out what are the triggers and what are the things that happen when someone is not seen and not valued. So that's what we're working on now.
Great. Jen, do we know if we have the slide on white supremacy ready to share that again? Because we had a question. This on white supremacy mentioned the language of indicators. Can you expand on what that means?
We're bringing it up. Oh, there it is. Is it on this deck, Dr. Joia?
It is, but it was,
I think it's slide 7.
I think Dr. Joia was thinking about a different question, but let's do this one and then we'll quickly. So I think the question here was, you said allows freedom to explore language of indicators. And they just wanted a quick.
Right. So the problem was, so we have this is a combination of 2 slides, and there's another slide that has indicators versus frameworks. So I'll try to explain it without that slide, but I was, so normally we have a slide that says also there are indicators and there are frameworks. We are currently, indicator is something like gestational age or marital status or all the things that y'all, the indicators y'all love, but you don't ask yourself under what framework did you pick these indicators? Why is marital status something that you still use as an indicator of what? What success?
Why do we collect the data we collect?
What are you checking the data, right? So it's a slide that talks about the difference between an indicator and framework. So our current framework is white supremacy. So the indicators that we are using are indicators that get us to white supremacy. So the belief in the need of marriage, right? I can be married and be in a domestic violence situation and not be supported. I could also be partnered and have an amazing security. So what is marital status? Why is that the thing that we're asking for? If we're asking for social support and safety, we should ask that. If we're asking for if a person has wealth, we should ask that. But marital status does not equal social status, does not mean safety, and it does not mean wealth.
Really helpful. Dr. Joia, you had asked for, oh wow.
So this is the normal slide. So an indicator is not equal to framework. An indicator is a measurement of our current reality. So marital status, as a product of our past indicators of systems are more adept. So yeah, that's it.
Okay, that was a perfect description. I think you had wanted to see the circular slide of the framework.
Yeah, I'm sorry.
So Jen, if we could go back to the original slide set, and then it's like slide 9 or 10. Jamie, while we're pulling it up, any other? So we're one more.
My guess is we're going
one more. I think it's the next one.
Yeah, so here we go.
Okay.
So when we interview the first, this is published. Susan, can you put the article in the chat maybe?
Absolutely.
So when Susan and her team interviewed folks in multiple cities around the United States, and then we went to the CBOs to ask them, how do we create from what they told us a framework? So this framework was created by patients and by CBOs. And they took us to the social justice literature. This is, we originally, because we're still like y'all, we're still super nerdy researchers. And so we had a hierarchical, we listened to it and we had this hierarchical thing, and the CBOs and the patients were like, you're just not gonna check mark. You're not gonna just check this off and you've now completed all respectful care and you're done. You're gonna constantly need to learn. So they gave us this cycle. We're like, okay, thank you. We're learning from y'all, appreciate that. So first thing we had to do was wake up. Right? So I had to unlearn that I don't have a Black pelvis or kidneys. That's waking up, getting ready, right? Then after you've worked on yourself, so all of you internally, before you jump out and say, we're gonna fix all of healthcare, you need to read and learn yourselves, get ready, change your own, gain insight. Then you work with other people, interpersonal, with the communities. Then, only then, can you go out and change in the community. So many folks jump to the community. Y'all gonna fix the community and haven't fixed yourselves yet. That's it.
Excellent.
So I'll turn to, and Jen, we can take the slide down, but so the next question is, AHRQ produces materials for health professionals to communicate findings, research, systematic reviews, and guidelines with the goal to improve clinical care. As we all have these unconscious and conscious biases, including doctors and other health professionals, do you have recommendations for AHRQ about how to communicate better to various health professional audiences, including those who may not acknowledge or agree that they have these biases?
Yeah. Well, I mean, I think the earlier conversation David and I were having about first acknowledging your own helps people. No one likes to be fussed at or told that they're wrong. So the more that you can find alignment when you're talking to whatever those agencies are, and show that you're also on your own journey of unlearning, because you are. None of us is there. Trust me. I talk to some very famous anti-racists and they're still unlearning things. We're all, it's so many ways that it shows up. It's so many ways that it's a lifelong journey for all of us. So I think that if you can do that, that'll be really helpful. I think as an agency, see yourselves as a place of power. I mean, you all were created to be the healthcare agency that made sure that the United States had quality. Lean into that. What would that mean to you? Like, what is your role in ensuring right now that we have a quality healthcare system in the United States? See yourselves as champions for justice. I mean, you're changing the world. You have an opportunity. I know you might think of yourself as a simple family. When I was a simple city staff employee running maternal child health, like it sounds small, but you have a lot of power. We were able to open up clinics in places that nobody had care before. We were able to provide people with access to mammograms that didn't have it before. That's the power you all have. You're great organizers.
That's a great reminder. Jamie, sorry.
Yeah, no, I mean, and I think I think the way you just answered this is touching on probably the answer to the next question that somebody raised, but I'll just say that, it seems that this framework, the framework that you're describing, these embedded principles of white supremacy are kind of mirroring the corporate structure that exists. And I'm sure many people have read all the Time series that have gone on really about how structural racism is really incorporated into all parts of America. But how do we, given that this construct, how do we change the corporate model according to true equity principles?
Yeah, it's hard. So the good news is that there are other nations who have a corporate structure, who have figured out a way to do this that we can learn from. We are probably we are a very diverse nation. So what usually makes us different from the other high income nations who also have corporate structures, but find ways to say, give everybody childcare, give everybody health care, is that they value all of their citizens equally, right? So like if you are in a Nordic country, it's a very corporate structure, but it is not racial capitalism. In this country, you can look at a person and know their job almost. I want my grandchildren not to have that experience, right? Like people assume when I'm in a hospital that I'm cleaning up or picking up dishes. They don't assume that I'm the physician. That's because of racial capitalism, that we've stratified people's jobs based upon what they look like. And that corporate structure then gets codified into how we do things like don't have healthcare for all or don't have paid leave, because those biases show up in our politics and who we value and how we vote. And so that's where it becomes really fraught. So our ability to see all of us as equally human, despite income, education, geography, religion, that's going to be the challenge for America. That's really where we are. So I'm optimistic that our exceptionalism will show up when we really believe that we can invest in with our corporateness and we love the money, we big dollars, all that stuff we love. Okay, we'll live it for everybody. Like have basic income for everybody. Believe that all people should have access to healthcare. Like people shouldn't die from COVID. That's revolutionary. So, my real fight the power abolitionist friends don't think it's possible. They don't think that you can both love money and love people. America could try to prove that wrong.
Thank you. And I'll say that's it from our end, David. And I know we're approaching the
Yeah, we're close to time. So I'd love the chat to start people saying, yeah, there we go. And thank you, Paravash. People have been really engaged, which is a sign, I think, of a good dialogue. Thank you so much, Dr. Crear-Perry, and to your entire team at NBC for your work and for spending this time with us. I look forward to sending with Jamie and the rest of our team all the materials. People have asked if we can share the slides. Of course, we'll make the slides available. Other slides like the one you shared, if you'd like to share.
I would love for AHRQ to make its own framework, and I would carry it around in my slides. And this is the AHRQ framework. I have a Louisiana Health Department framework for health justice that I carry around in slides.
Well, we are taking you up on that. We're starting our work on trying to come up with our framework for health equity, but I think you really laid down a challenge for us. If we are the agency that the government, that the structure created to drive quality, how are we going to use that power? And the idea that we understand that without equity, without health equity, there is no quality.
Yes, that's it.
And that's
You're a
going to
small
lead.
but mighty team. I have faith in you. You can do it. We can do this.
Let's do it together.
Yes.
Thank you again. Thank you to your team. Thank you to you in particular. Thank you to everybody at AHRQ for joining us. Let's keep doing this hard work together.
Thank you.
Be well, everyone.